And thank you very much for the invitation. How should we use health records to understand the harm and benefits of prescribed medicine? We have just heard some excellent talks on randomized trials and why we normally use those, but there are many concerns of drug safety that are unlikely to be resolved within the setting of randomized trials. Some of the limitations are listed here. First of all, many of the randomized trials are limited in size, so rare but very important side effects may not be detected. Also, there may be unexpected adverse effects that not have been accounted for when they designed these randomized trials, and they will therefore not be recorded. There is limited follow-up time. It costs a lot of money to run these trials, and that may prevent the detection of long-term adverse effects. And then often these are designed to be very narrow, including very specific targeted groups, and therefore often avoiding vulnerable patient groups that may have a different response to whatever is studied. Concerns of cardiovascular safety represent the single most common reason for safety withdrawals of marketed drugs, and I've just put a few up here. So it's really important to study. And there I risk to say that the observational study is a real alternative in many situations. Before I go into this, I'll just describe some of these materials that I think are needed to really work with this kind of topic. I'm coming from Denmark. I'm coming from a society that has actually registered its citizens in great detail since the 1960s. So we got this PIN number in 1968 for tax reasons, and everything has been actually recorded by this PIN number. It has been an investment worth billions of kroner, not for research purposes, but really to develop a society that is balanced and actually give each citizen what this person expects from society. But it can be used for research purposes, so we can follow the individual from birth to grave, diseases through generations, and you study millions of individuals, and therefore in some different designs, these results are very robust. I know that also in Scotland and other areas of the UK, you're actually getting, maybe not exactly this kind of data set to work with, but you're getting there in a lot of different ways. As you can see, it's not only a lot of different characteristics that we have, but we also have very large biological biobanks to go with this. So we can study life course epidemiology in Denmark. From birth to grave, we can study an exposure being a drug and what effects it might have on a lot of different issues, and I'm coming back to that. And then you also have all the blood specimens from the biobanks, so you can study actually what's happening individually at the same time. Here I've illustrated the research platform that we work with in Denmark. So you have the CPR number, the PIN number, through which everything is linked. We know in great detail a lot about diseases, drug exposure, vaccinations, but also to the right here, lab results. So we are developing a registry in Denmark that actually is a copy, that takes a copy of all lab results sent to physicians around the country. So you can imagine millions of data every week are coming in this way. Urine samples, blood samples, whatever, all the results are coming into this registry. This is the platform. And then we have this marvelous National Drug Prescription Registry. It was meant or designed really to give chronically ill a reduction on the price of their medication. So when someone is coming into the pharmacy with a prescription, as illustrated here, and it's keyed into the computer, in microseconds, the pharmacy will know whether this person has already bought for, say, 1,000 kroner medication, and therefore will be given a reduction on the price of his medicine. But it also can be used for research purposes because it contains a lot of detailed information on what this patient is given, not necessarily what he's taking. but at least what he is given. And for that reason, it can be used for a lot of different purposes. So you can use this to actually study post-licensure effectiveness studies. You can study long-term use of a particular drug. You can study new indications of already licensed drugs. And drugs that are given for the same condition but have never tried in randomized clinical trials can be evaluated up against each other. And you can study drug-drug interactions. And of course, we are all getting older, and therefore also issues like polypharmacy that are really nearly impossible to study in randomized clinical trials can be addressed in these registry-based large cohort designs. But as we already have heard, observational studies have methodological challenges. Treatment is not randomly assigned. Participant characteristics may systematically differ between treated and untreated subjects. So difference may introduce confounding and threaten study validity. There have traditionally been used different ways to get around this. I'm not discussing those today, but we'll rather discuss some of the ways that we try to address the problems with those issues in newer designs. The first one is the new user design. So whenever we study a drug and its effect, we try to only go in a cohort design at time of first use of that particular drug. So we don't want to really study prevalent users, because there may be many issues here that actually will bias our results that way. That restricts somehow some of the concerns. Then we often do comparative study designs, so we never go with someone who did not take that drug. We want to compare with another drug given for the same indication to make sure that we have the populations that way at least controlled. And then I think what is very important is the summary score methods, and in particular propensity score, which is the individual probability of treatment or of being exposed given pre-treatment characteristics. And these pre-treatment characteristics can be many. They can be sex, age, but they can also be what kind of chronic diseases or other conditions the person has. All these, and there's also the disease risk score, where it's just the individual probability of the outcome. But it's really the propensity score that we are working with, because it allows really that large quantity of data on potential predictors of treatment choice to be summarized in one single score. And they can be many, as I said. So they are summarized in one score. By taking this score into account in effect estimation, either by matching or adjusting, or characteristics included in the score are simultaneously controlled for. So in studies with a limited outcome event, estimates are less biased and more precise than traditional multivariate regression. And often when you deal with adverse effects, the outcomes here are very rare. And you can't really adjust for a lot of different covariates here. So we use a propensity score. And I just will go through a few examples using that. And the first is the user ran decline for smoking cessation and risk of serious cardiovascular events. This was a nationwide cohort study. And we did this because there was a randomized clinical trial that had found a higher rate of cardiovascular events among users of viral decline compared to placebo. What we did was to do this propensity scoring of a very large cohort, and then did a matched, what's called exposure, and those being exposed to viral decline, and a comparative drug, bupropion. And having done the risk score matching in those exposed and those not exposed to viral decline, you can see how well they actually are actually aligned in these characteristics. And then when you do the risk evaluation after 6 months follow-up, we were actually able to show that varenicline did not increase major cardiovascular events significantly. Another example is the use of azithromycin and death from cardiovascular causes. Here, an observational study had found an increased risk of cardiovascular death associated with this use. So what we did again was we took a large population-based study, all persons in Denmark, specific age group, specific period. And then we did two main analyses. One was the azithromycin versus no use of antibiotics in a propensity score matched analysis. And then secondly, we took again the drug azithromycin versus penicillin in a propensity score adjusted analysis. And I don't really want to go into the details really. Here is just to illustrate the way we work, that in the first propensity matched analysis where we matched against no treatment, and even though we propensity matched, we saw an increased risk of 2.85. But if we did a comparison study and propensity adjusted this, we did not see this increased risk. I'll just bring a few other examples of how we work with these registries. Some years ago, use of angiotensin receptor blockers were incremented as increasing the risk of cancer. This was a large meta-analysis done and published in Lancet Oncology in 2010. It increased the risk of cancer by 1.08, and it was in particular lung cancer that was incremented. So the EMEA actually contacted us and asked whether we could address this because they were concerned about what to do about this. So we did a large cohort study along the ways that I've just described. And were actually not able to find this increased risk in this meta-analysis of randomized clinical trials. Remember here that cancer was not the outcome of the study. I mean, this was a secondary outcome. And randomized clinical trials have difficulties as soon as you get into secondary outcomes. So we found 0.99, 4% risk increase could be excluded. And also, if you look at the duration over time, there was no indication of an increased risk of cancer. There's an area that is that is impossible, more or less, to perform randomized clinical trials in, and that is small children and pregnant women. So typical official recommendation is use of a particular drug in practice, insufficient safety data, blah, blah. We don't have that information. And here again, the registries can actually help out. One example is PPI, where we did a study on proton pump inhibitor use in early pregnancy and studied whether they increased the risk of birth defects as it had been suggested earlier. And in a very large cohort study, we were not able to see that it was increased significantly. Another way of working with this is exemplified on this slide. We have worked a lot with pyloric stenosis in my group, and I'm not coming into this today, except I'll show this study on macrolides. Because macrolides have been given to newborns when the stomach were not working and they couldn't really get the stomach really starting to work, so to speak. And the pediatricians actually thought that macrolides made the stomach cramp and then the stomach would start working. But there have been a lot of case report in series actually indicating that macrolides might increase the risk of pyloric stenosis. So we did this, again, nationwide population-based study for macrolides, where we did not only study the macrolides in infants, but also in the pregnant mother. all through the pregnancy and compared with penicillin use and also no use. Here is illustrated the risk increase early in pregnancy. There's no for a woman that takes it during pregnancy. The last trimester, it's a little up. It's still not significant. But if the mother breastfeeds the child the first 14 days, the child has a 3.5 times increased risk of pyloric stenosis. If the child itself takes macrolides, it has an increased risk of 35 times. After 14 days of breastfeeding, there's no increased risk in the mother, of breastfeeding, so this looks safe, and the child is still a little increased. Those kind of data could never be, or at least very difficultly, be obtained in randomized clinical trials. And we've done a lot of similar studies. There are examples here of new indications for already licensed drugs. There are examples of studies that have been tried up against each other, where we didn't know whether one was more effective than the other. And there are a lot of trials, or a lot of studies, I should say, on pregnant women and the effect of a drug in pregnancy and small children. But just to show the strengths of this kind of data. And I'll finish by including the biological samples in this kind of design. So in Denmark, we have established the National Biobank, which to the left here is a physical biobank at my institute that contains more than 6 million specimens from more than 3 million Danes now. And we have a register here to the right that combines the larger biobanks in Denmark and combine it with the registry information to the right here and make it available on the net, so you can all look up National Biobank DK and play with it and ask the question, say, does this bank include 400 specimens on multiple sclerosis patients, this age group, this period, only males, or whatever you like, and it will give you an answer. We are using this for a lot of things, but of course, first of all, for pharmacogenetics or personalized medicine, it is a wonderful tool. So here you have a patient group that takes a drug. Some respond to this, others don't. It could be statins. Then you can go to the biobank and take out the DNA and actually study why some respond and others don't. You can, because we have all the laboratory values for the entire country, study all those that have high cholesterol values, say, and take statins for the first time, and then you can wait and see what happens to the cholesterol values or LDL or whatever you are interested in after a certain period of time, see those that really respond, those that don't, go to the biobank, take out the specimens and study again why some respond and others don't. This is I would say, old example, but I think it's illustrative. Loss of function mutations is something that interests all of us that actually want to find new drugs. And we have heard about the PCSK9, loss of function, that actually reduces the LDL cholesterol 40%. But we all have loss of function genes. We all have approximately 150 loss of function mutations, but they are different. But they're likely to have functional impact. And it has just been discussed earlier today how two companies have developed a monoclonal antibody that blocks the PCSK9, and they have reported astonishing and similar results, and a third company is actually ready to also be on the market soon. But based on all this, I have a dream that actually we are working on in Denmark, which is the 1 million fevers, because there are many of these loss of function genes and similar variants that may play a role that should be discovered and are yet not discovered. The other day, Nature had a new paper illustrating that even within the UK, 13,000 sequenced, they haven't found new targets or new things, really. And we are more and more that actually believe that numbers are really important here. And instead of sequencing tens or 20,000, you should probably rather genotype 1 million or 2 million or 3 million. That's really where the big discoveries are coming in the future, the forthcoming years, I think. So in Denmark, based on the biobank, we're trying to actually find funding right now to do what we call a FIVAS. So we go from having all the genome-wide association information, and there you can find 800 that may have a loss of function in one particular area, and then compare them with all the rest of this million. Go down to the rich database that we have in Denmark with all kinds of covariates, not only disease outcomes, laboratory values, whether they have a family that live long or not, whether they are, fertile or not. But all this enrichment of this database can actually identify a plot that turns around the picture from what we are normally used to. This time, it is all kind of conditions. It's not the chromosome and all the variants down here. It's the conditions based on a particular variant, based on a particular loss of function. This is really, I think, the future in translational medicine. I will end just by illustrating in a different way how we have worked with adverse effects. This is not from a drug, but vaccines are really also drugs. And in Denmark, we have this database where we have information on all children and how they are vaccinated with what vaccine and when. And we have developed, based on this marvelous register that we work with. And we use this to ask the question, well, first of all, this is an old study we did some 10 years ago, where we actually studied children that had had an MMR vaccination and their subsequent risk of febrile seizures. And these kids develop febrile seizures between day 9 and 14, or 9 and 12 more or less, but in the 2 first weeks primarily, and thereafter there's no increased risk. So knowing this, we wanted to actually study whether we could predict those kids that develop febrile seizures. So we went back to the biobank and took out 1,000 kids that had an MMR-related febrile seizures, and then control children, and then 1,000 that had an MMR-unrelated febrile seizure. Then we took and did all these different designs. So we have also MMR-unrelated febrile seizures versus control, and overall febrile seizures versus control. But up here, this was the MMR-related febrile seizures versus control. By doing this, we were able to find 2 loci that were specific for the MMR-related febrile seizures and 4 that were more general. Some of these variants are in the sodium channels and really targeted for drugs or future drug development. And it really created a lot of attention, because we haven't seen that many studies really addressing adverse effects this way. I think with this example, I've illustrated how we can actually go forward and hopefully work more towards precision medicine, also using data from registries and observational data. Thank you very much.
Thank you very much, Mads, for an amazing tour of what's going on in Denmark. Is there time for one quick question, perhaps? Yes. Thank you.
In the UK, there is tremendous resistance to the sharing of demographic or clinical information, even for routine clinical purposes. What form of debate was there, both at the outset and now for control of use of the data in Denmark?
There didn't used to be, I mean, in the old days, there were no discussion at all. We grew up with this system, all of us. And we have seen the tremendous advantage of, having all this data. We get also a good treatment from the society, having paid a very heavy tax. But I must say that in more recent times, and with all the scandals that have been international, we also had some in the country, the debate has become more intensified. And it is a challenge to keep the Danish system the way it was, also because of the discussions in the EU and around integrity and so forth, because we are part of the EU. But we have in Denmark certain, we have an opt-out registry. So people that don't want to participate in studies where we make use of their biological samples collected in the healthcare system can actually register in that opt-out registry. And we're actually discussing other measures similar to that to actually increase the understanding from the public that we continue to use all this data the way I just described.
Okay, thank you very much. And our final